afternoon and a warm welcome. I'm Dr. Suchita. I'm the Senior Medical Advisor associated with Procter & Gamble Health. And today we are discussing about telemedicine. Now, doctors study telemedicine as a system is definitely evolving, and it was evolving. But due to the pandemic situation, suddenly the doctors have to acquire the skills of the optimum physical examination, which were not taught before. Let me share my screen. There are advantages of telemedicine from the pediatric point of view. It's cost effective, it saves time, the follow ups are easy, and there's a reduced exposure to infections. But there are disadvantages also. There are technical obstacles, the internet connectivity problems, medical legal issues are also there. But the major issue remains the same, that how to diagnose a case over the audio consultation or a video consultation. Now, given the need of the social distance for the foreseeable future, we'll all have to put together our brain to see to learn that how we can improvise the physical examination over the telemedicine. Now, if I only focus the ENT examination, and this part of the body can be very, very challenging because the ear or nose, these are very small orifices, and one require a ambient lighting, a good camera resolution, and also the doctor's experience matters a lot. So new sets of skills has to be acquired for the ENT examination. And to do that, our attempt to have a webinar on remote and virtual ENT examination and taking the advice from the experts. Now, I have two eminent speakers with me. Our first speaker is Dr. Jagdish Chinnappa, who was the head of the pediatrics in Manipal Hospital. Sir, I think, has the interest in pulmonary medicine, ENT, neonatology, psychology, and he's the current president of respiratory chapter of Indian Academy of Pediatrics. He has been the faculty of various national and international forums of pediatric forums as well as respiratory forums. So, sir, it's our privilege that you have accepted our invitation and you're there to guide all the doctors. Our second speaker is Dr. E.V. Raman, who is the consultant ENT surgeon. He's the head of Children's Airway and Swallowing Center at Manipal Hospital. There is also the chairman of Pediatric Otolaryngology Subcommittee of Indian Association of Otolaryngology and Headache Neck Surgery. I think very apt. Sir's experience, considering his pediatric experience from the ENT perspective, will definitely add value in today's session. And we have our third speaker. He's not a doctor, but he's an expert. He's the digital photographer, Fardeen, who's going to take a workshop for all of you how to capture the high resolution images and how to capture videos which will enable us to diagnose the ENT conditions. So we have few case studies with us and let's discuss these case studies one by one. So the first case study that we have is a case of fever and sore throat. So Miss ABC connected with a doctor on video call with her 5-year-old daughter and tells the doctor that her daughter has been complaining of sore throat and mild fever for past 2 days. Upon questioning from doctor, Miss ABC denies having a runny nose, cough, mouth sores, or voice hoarseness. Now let's understand from experts how we can examine this child over the video consultation. Now the primary complaints are mild fever and sore throat. So if you see from the audio consultation and from any video consultation, these are the basic things that any expert can understand. Now, I think I would like to request Dr. Chinnappa, sir, if you can give us the insights for basic ENT consultation, which is still possible over the audio or video consultation. Sir, over to you.
Thank you, Dr. Sucheta, and thank you, PNG. With Dr. Raman, thank you for inviting us here today. Yes, we are in challenging times. Last 6 months has changed the way we examine children and we get history. And I'm very happy with the first case that you have put there. It's a simple case, no doubt, that the child has got throat pain and fever. And I think it's important for you to basically ask a little more history and get a little more clarity. The first step in any teleconsultation is to get a proper history. So you need to find out how bad that pain is, how, whether it is disturbing sleep, whether it is disturbing food intake, whether it is causing any excessive salivation, difficulty breathing. You also need to know whether the child has been vaccinated, because you see one of the conditions which is suffering is diphtheria. So you need to know whether vaccination has been done or not. The other thing which you also need to do is to look at the child. First thing is look at the child and see whether the child is well looking or sick looking. If the child is not well looking and if there are some danger signs, do not attempt to do anything further. Refer this child to the hospital straight away. The next step after that is you see whether this child is well looking. If this child is well looking, then next step you tell the mother that you caution her that you are doing a substitute to physical examination. You may not be right all the time. So therefore, if there is any worsening, they have to go to the hospital. Within the constraints, what you can do is to have a look by two methods. Either you can ask the mother to flash a flashlight and see the throat and the nose and the ear, or you can ask the mother to take photographs of the throat, of the nose, and ear is difficult to take unless you have got an instrument which can take a picture inside. But basically, nose and throat can be very easily pictured. You can take a picture and send it to the doctor. So, and the very important thing at the end of what you see is to tell the mother that if there are red flag signs, to contact you or to go to the hospital emergency. So I think the important thing in telemedicine is to impress on the mother that the most ideal thing is to do a physical examination, but because evaluation of the throat and nose is an aerosol producing thing, you are taking a shortcut. And you can take a shortcut by doing three main things. One is getting a proper history. Two is trying to put a flash and looking at the child's throat, looking at the general condition of the baby, and finally taking a photograph and reviewing. So these are the ways you can get around in the current situation.
So thank you so much, Dr. Jagdish, and it was definitely insightful, and that actually shows the importance of history, which remains even for a physical examination, even for a virtual examination. Dr. Raman, any points to add from the ENT's perspective, from the ENT specialty perspective?
I think Jagdish has covered most of the things, but this is not the natural way we examine and treat patients, so it's unusual. So we need to have, if not the best, the second best, and this is the second best option. And we are choosing the second best option for three major reasons. One is, of course, you can triage the patient. Does the patient require immediate hospitalization or can be managed with video consultation? That is number one. And you can warn them that they may have to visit the hospital. At least that part you can check out. Secondly, as he said, that history is very, very important. Since we don't have field touch for the patient, history we have to exploit much more, make the mother or the father, the caregiver, part of the team and help us in every possible way. And as you know, in pediatrics especially, it is very important because 27 to 40% of the cases have some ENT related issues. So it's very important we have this meeting today and see how best we can examine the ear, nose and throat, which are not exactly only on the surface. The ear, for example, is a canal. The throat has got the oral cavity, which you cannot look deep enough. And the nose, again, you can't see the back part of the nose. But in spite of that, with our current phones available and all that, that's been a major asset. And so we can do video consultations. And many of the cases you can take care and avoid them to come to the hospital, get exposed to the others. So in that particular way, it's very relevant. And a couple of questions apart from the based on these on the findings of the children have to be asked. We have to ask leading questions and check out once, twice or thrice and make sure that we are getting the right kind of information. Now, this particular, you put these two columns on audio and video. Yes, audio can also be used. That is the important thing. Like when the child coughs, is there any change in the voice? And even to some extent, the hearing impairment part, we can ask the mother to find out any gross problem in the hearing impairment. Then wheezing and can be heard. If the child has got noisy breathing, we can place at which part, whether inspiration or expiration, where it's taking place. The type of sound that comes when the child breathes, whether it's coming from the nose or from the upper respiratory tract, we can find out. And the video, of course, gives additional information. And I'm sure you're going to have some more slides going into the details. I will not come in the way and we'll comment as you progress with the slides.
So thank you so much, Dr. Raman. I think you were like absolutely correct. So most of the stuff we can do it over the video consultation. Now, if I back to the case, the most tricky part will be the throat examination, and definitely from Dr. Jagdish we can learn a lot from the throat examination perspective. Sir, any insights, especially from the tonsillitis aspects or a pharyngitis aspect?
I think it's important that all practitioners to watch about the centaur criteria. The centaur criteria is very simple. If you basically, what do you want to distinguish in a throat is: one, is it a serious condition like diphtheria? Two, is it likely to be viral or bacterial? These are the three questions you need to answer straight away. Now, if it is a serious condition, definitely don't waste your time. Send the patient to the hospital immediately. If it is not so serious, then you need to differentiate whether it is bacterial or viral.
Yes.
If you don't have cough, if you have basically a discrete involvement of the tonsil, if you have got a lymph node swelling, which is coming under the tonsillar area, jugular-digastric area, if you have those kind of things and you don't have a cold and a cough, then you may be dealing with a streptococcal pharyngitis. Again, the important thing to realize is there is no urgency to start antibiotic. You still have got time for about 7 to 10 days to start an antibiotic. Because if you want to prevent the complications of a sore throat, you have still time. So you can always review in 2-3 days time. So you can ask the mother to just give simple paracetamol, wait for 2-3 days, see how the child responds, and come back for a review. I think the key thing in a teleconsultation is that you need to review frequently, more frequently than you do in a physical examination. Because there is always that gray area which you are not able to really say yes or no. So I think it's a combination of this skill of taking good history, the skill of eliciting whether this is a serious condition or not, the skill of talking to the parents and telling them the limitations of telemedicine, and the skill of having a regular review back when required. I think you need to put all this together and not rush into start of an antibiotic. It's not really necessary. I think what is important is to think through all this and then start. I'll just give an example. I have a child right now with 2 weeks fever and no antibiotic was given. Okay, the mother was telling me, why no antibiotic? I told her, still we don't think that this is bacterial. And this entire thing has been done in combination with the ER and our home. So I think the important thing is that we have to remember our limitations with the teleconsultation. Another very important thing I would like to give all the viewers is document everything that happens in a teleconsultation. Okay, write it down, send it off as a prescription, keep a record of what has been taken place between the parent and you. Because it's very important that you document it in the teleconsultation notes. Okay, if you don't document and something goes wrong, you can be held liable legally. So I think these are things that people should realize.
So I think I completely agree with you, Dr. Jagdish, and because it's still a gray area, and sometimes the consultation is so difficult over the video consultation. I mean, doing all the maneuvers to actually look at the throat, and we might not have the clear picture also. But certainly we can do some things like the lymph node assessments. And now I want to request Dr. E.V. Raman if he can actually tell all the audience about small tips that the lymph node assessment can be done by parents as well, and how we can enable to do that. Dr.
So one of the important things is that it's doctor involvement plus the patient involvement. It has to be a to and fro communication, because you're not dealing with trained health workers to help you. So here what you need to do, you must make the mother or father part of your team, and you have to always explain to them why you are asking for that particular test. So once they understand, they get involved much more. For example, in this particular picture, we are talking about the swellings in the neck. So we need to explain to the patient, you're looking at the neck to see whether there are some telltale swellings of the lymph nodes, which are the initial guardians of any infection going from the throat, and the pattern of the swelling, whether it's painful, not painful. And since we don't have the benefit of a three-dimensional assessment, they need to use, like it's been shown in this particular picture, to press, then you get the depth perception, although you don't really have a depth perception, to see how much enlarged the node is. And the mother can just go around that area. And many times you ask the mother or father, and the doctor himself keeps the finger on his neck and demonstrates to them which is the front part, which is the back part, so that they kind of understand, and we know whether it's the posterior group or the anterior group, which makes meaning to us but may not be explained to them. And also, it's important to ask them a couple of questions regarding how soon, how much time it took to develop, whether it was a single node which has become larger. Some parents are very observant, they'll tell you there was one and today there have been four. So you correlate the information you get acoustically, that means on speaking, with the picture. Now again, you did mention the importance of still pictures. I think that's very important in children, because that particular moment when you want to see them, they may not be in a mood to sit down in front of the camera, or there are some children who are hyperkinetic, they may walk around, get distracted, etc., etc. I think the suggestion that you've given about still pictures, which is taken when the child and the mother or father is alone, the quality will be much better and we'll know exactly what to do. So all this requires a to and fro communication for them to understand why you're asking the question. And to add to what Dr. Jagdish is saying, to separate children who can continue in video consultation and the children who need to visit to the hospital, we need to tell them about some red flags. Today the child may be all right, tomorrow day after. So you tell them, if the breathing difficulty gets worse, if the fever goes much more, child refuses feeds, maybe you need to come, or whatever, depending on the condition. As far as the ear is concerned, again, you have to tell them that if the pain is continuing for a longer period of time, child's fever is more, or the child has got some imbalance, that we could be treading into the area of complications. So give them the red flags, 1, 2, 3, 4. If this happens, get to us earlier. If this does not happen, we can wait and do the repeat consultation later. And what Jagdish said was very good, very important about the medical legal aspect. And then tell them that the hospital doors are not closed to you. It's there. We are doing this particular thing for this particular reason, but we can always take care of you, because ultimately it should not happen that we gloss over and say this is a trivial illness and it turns out to be one of those rare complications.
So I think I want to conclude that the red flags, and that's something at least we should always keep in mind during the video consultation. And thank you, Dr. Raman. I mean, again, to reemphasize, and to Dr. Jagdish also to bring that point. Now, quickly, if I move to the second case, and this is the case where the child has come with the runny nose and non-productive cough, and along with the mild fever. So it's a simple case of a fever and a runny nose. Child is now irritable, and that's why the mother is opted for the video consultation. Now the nasal discharge or nasal rhinorrhea is the major complaint. So from the examination point of view, Dr. Jagdish, what do you want to add? The simple rhinitis patient, I mean, how we can diagnose rhinitis and the types of rhinitis, like non-allergic or viral or allergic rhinitis, over the audio or tele consultation?
Sorry, I think what we need to understand here is to understand why the mother is calling you again.
Yeah.
I think if the child has got a little cold and she is worried because the child is irritable.
Yes.
So the irritability is what is troubling her. And what can cause irritability in a child at that age? Basically, nose block is one thing which can do it. A ear infection can do it. If there are ulcers in the throat, it can happen. It can happen if there is laryngitis. It can happen if the child has got bronchiolitis or something lower down. So the first step here is to rule out something that is serious. And what is the serious part of it? The serious part of it is something lower down. So you just tell the mother, is this child breathing normally? Does this child have high fever? Does this child have any retractions? Is there any inward movement of the either the neck or the side of the chest or whatever? So I think the first thing is to ask the mother. Second is to look at the child. From these two things overall, not go straight to ENT. Next step is look at the ENT part of it. You try to look whether the throat seems okay here. Now, if you look at the nose here, nose also seems all right to me. There doesn't seem to be anything excepting maybe a little block on the left side because I'm looking at it from there. So what here is to distinguish between a viral and an allergic is not that critical here. At the end of the day, both of them will settle down. If you had fever which is predominant, no repeat episodes, more viral, more likely. If the child had sneezing, watering eyes, not much of fever, itching of his nose, then more likely to be allergic in nature. So what I would do here is not worry too much about it. Rule out the serious conditions first and then go on the most likely diagnosis, because both of them temporarily, whatever treatment you give will settle down over 3-4 days.
Yeah.
I think that's the way you need to look at it. Because again, exactly I cannot say. See, the one thing which we cannot really rule out is a ear infection.
Yeah.
And we now know And we now know that there is no critical urgency to treat a ear infection, okay, unless there is very high fever or severe ear pain. If there is pain which is manageable with simple analgesics and some decongestant nasal drops, there is no hurry to start an antibiotic even for a ear infection. You can what is called as have watchful waiting, wait and see how it progresses over the next 2-3 days. If the child gets more pain, more fever, then you might start an antibiotic. Till then, you can just hold on.
So thank you so much. I think these all points are very, very practical. Dr. Jagdish, I'll again come back to you, considering that you have to leave this meeting around at 3:55. So quickly, if you can enlighten about the sinusitis, and is it common in pediatric patients, and if you feel that if that's the differential diagnosis, and if you can give some tips to evaluate it over the video or audio consultation.
I think the setting of sinusitis is very important. The first thing is there are 3 types of sinusitis in children. The first type of sinusitis is a child who starts off with a cough and cold and goes in for very high fever, facial tenderness, etc. So that's the severe toxic form of sinusitis. The second form of sinusitis is a sinusitis where the child starts off with a cold and cough, goes on for recovers from that, then a week or 2 week later, about 10 days later, starts getting yellow discharge, pain, fever. That's the second variety. And third variety is the one who is very indolent. That is, there is some nasal discharge, some fever going on for 2 weeks, 3 weeks, etc. So I think what you need to do is don't start diagnosing sinusitis on day 1 and day 2. Most of the time it's a viral upper respiratory infection and it will settle down. If the child is very sick and has the severe form of sinusitis, he needs to be in hospital immediately to confirm and start the proper antibiotic. I think the important thing is sinusitis is not a medical emergency. Sinusitis, excepting in very rare cases, in that situation, it's usually follow a course. Follow the child, see how he responds. Yeah, you can get tenderness, but tenderness is not often seen in the second and third variety. Tenderness is seen more often in the first variety of sinusitis. So I think the important thing here is to don't rely on that. Rely more on the pattern of the disease, on the nasal discharge, on the child running fever on and off, and then probably look at sinusitis as a possibility.
So I think thank you so much, Dr. Jagdish. And actually, in between, I really from the heartfelt thanks from the PNG Health. All the pointers that you told to the audience, I think these are all valuable. You focused on the identifying the red flags. You focused on the really good history taking. That remains the crucial, even if it's a face-to-face or even if it's a virtual consultation. And again, as you mentioned, there's always a gray area. So the proper documentation will always helpful for us and even for the patients. So thank you so much, sir. I like we are very feeling sorry that you have to leave in between because of the other commitment. But thank you so much, sir, for all the valuable time and all the insights that you have shared with us.
Thank you, Dr. Raman. Thank you, madam.
Bye. Yeah. Bye. Goodbye.
So doctors will continue with the meeting, and we have Dr. Raman as an expert who will actually give us a lot of additional points on allergic rhinitis and the ear examination bit. So Dr. Chinnappa told us a lot about.
Just quickly go back to the sinusitis. Just 2 points I just want to just outline that. The important thing is, see, the lining of the nose and the sinuses is all the same mucosa. So every time a child has rhinitis, it is also sinusitis. Not the way we understand sinusitis. That's why the word rhinosinusitis has come in.
Yes.
So we must understand there is. But then sinusitis per se, we use separately the term when the cold becomes slightly more unmanageable. And usually there is intense inflammation either due to the virus or due to bacteria. So the bacterial rhinosinusitis is what is called as ABRS, acute bacterial rhinosinusitis. But you must remember that ABRS is preceded usually by rhinitis, which is a viral origin. So as Jagdish pointed out, antibiotics is a no-no in the initial stages. And many parents want their children to recover fast. They feel antibiotics will relieve them. One of the challenges is to explain to them why you're not giving an antibiotic. A doctor was once asked, why did you give an antibiotic for a patient? They said, because it's there. Now, it's not like a mountain. A mountaineer goes because the mountain is there. We should refrain, and it also takes much longer to explain to the patient why you're not giving it than giving it takes 2 seconds. So, use of antibiotics is very important, that we should restrict the use of antibiotics. And this, but very rarely children can get complications of sinusitis, which is another thing. They could get orbital cellulitis. The other complications are much rare, in which the eye gets swollen up and it projects out, and that can be very easily and nicely seen in the video consultation. I'm coming back to, you can notice the complications. So you can go ahead with the next slide. I just wanted to add these two things in children.
So, sir, definitely valuable from the sinusitis perspective. And as you mentioned, it's not actually separated. It's actually the combined rhinosinusitis as a terminology, because the nasal mucosal lining is the same. If I consider rhinitis, then the major also the prevalent in our country is allergic rhinitis. And sir, if you can enlighten us, if we can also manage allergic rhinitis patients over the video consultation.
So here, as usual, history is very important. Once you take the history, you know whether the symptoms are acute or whether it's acute and chronic, and secondly, the duration wise. That is, whether it is seasonal or whether it is perennial. Also called intermittent or sustained rhinitis, which continues for a long time. And so seasonal variations should be there, could be there. Now, once you see the child, a lot of telltale signs, just examining a child physically or even in a video consultation. So this slide here brings out all those things very nicely regarding the changes in the eye, then the famous allergic salute where the child keeps taking the hand palm and tries to, with the itchy nose and little dribble, tries to control it by doing what is called the allergy salute, and those shiners below the eyes. These are the very obvious. Once you see the child, you know this child has been having has an allergic predisposition. The shiners, the dark circles below the eyes, etc. And also other characteristics are the sometimes they also have adenoids, enlarged adenoids, which in a particular age group where it makes the allergic rhinitis sustained for a much longer period of time. And these children have breathed through the mouth because of the nasal obstruction, and they are habitual mouth breathers. So it's adenoid facies is what this is called. So all these things can be very easily appreciated I think this is one of those places where video consultation is almost not the same, almost as good as the regular physical examination for the child. And once we establish the time period in terms of seasonal or perennial, and then we go on to and another important thing is what happens to the child is important. What I mean by that is no child is brought to you because child is having a running nose, sneezing, or obstruction. But what it entails in the quality of life of the child. The child cannot sleep. The child doesn't feel like eating because the postnasal drip, and also every time one morsel of food in the mouth, they have to breathe, opening the mouth. The interruption of feeds, they lose interest in that. School days lost, concentration, and in case the allergic rhinitis also produces some kind of a eustachian tube block and ear-related problem, lack of attentiveness in school because of a eustachian tube block, etc. So it's a quality of life which brings a child. The lowering of the quality of life brings the child to you. And allergic rhinitis in children is a double whammy because not only the child's life is disrupted, the parent's life is also disrupted. So it's got a multiplier effect. In these cases, like I said, a video consultation for this kind of a semi-chronic or acute, but not acute, we can really assess the child nicely and give the appropriate treatment and give relief both to the child and to the parents.
So I think, sir, the history and again the video consultation, the facial features, but again a very good history will definitely point out towards non-allergic rhinitis and allergic rhinitis, and then help us to manage that patient appropriately. Coming to the last case that we have, and this case is fever with earache, and the child, a 3-year child, is complaining of right ear pain, and there is no ear discharge. There is a mild fever associated with the earache, and the child has the history of mild upper respiratory tract infection around a week back. He has no history of allergies. Now, this child is maybe a typical case of acute otitis media because there's a prior history of upper respiratory tract infection. But from the ear perspective, how we can, what sort of examination can be possible, sir, in the video consultation bit? That's something we would like to understand from you, Dr. Raman.
So again, going back to the history, I'm sorry, coming back to history because it's still important.
Yeah. Yeah.
Fever with ear pain means fever is a very positive predictor of acute otitis media. That is number one. Now you come to the next slide, where we're going to, we come to the next slide. Yeah, so we're going to see the external ear. On the extreme left, you can see that ear which has got a little congestion on the of the pinna. You can see all that. You can see sometimes the discharge flowing out. Sometimes you will be able to see the secondary changes due to the discharge. Chronic discharge, it can produce some kind of a secondary dermatitis. In the second shot, you can see the thick, almost purulent, thick discharge, which is viscous discharge, which is coming out. You can see the color. And from the color, sometimes the color is green, you know that it's usually pseudomonal infection. And also we need to find out whether the problem is in the external ear, middle ear, inner ear, of course, doesn't produce pain, it produces other problems. So whether it's otitis externa or otitis media. So in the last film, you see that the child's ear is being pulled back, not only to examine the wax or any obstruction in the ear canal, but also when you touch that area, the child has got pain. When you pull the external ear, the child will have pain. And also the tragus, that is the part which is covering the ear canal, if you press, the child will have pain. So if you can make the mother just touch the child and see, many times we get a clue, or if it's an older child, you can ask the child whether when he pulls the ear, he's got pain. And mind you, children give you very important information. They don't get confused like adults, and they're always very, very accurate. And you can make them cohorts in our history taking. And sometimes they correct the mother. No, it wasn't yesterday. Day before yesterday, I got the fever. You're saying it wrongly. So use the child, so 7 years old, for all these things. And you can get a very nice picture of the external ear and the beginning of the ear canal. The blind area is post that. And I'm sure we're going to get some tricks and tips today as to how to do all those things. And also you must have a look in front of the ear and the back of the ear. Don't forget that. So all these things, the physical examination, we need the mother or father helping us, and they could be, again, some pictures could be taken as stills and sent to us. This is very important. And next, yeah, that's fine. I think that's about all in this case.
At this point also you have taken the ear examination, the tenderness. Sir, if you at least, if you tell that the various areas can be palpated by all the, by parents, maybe
That's
near
right.
the
That's right.
or the yeah.
And again, you know, the moment children keep putting their finger inside because they're feeling discomfort. If the pain is not too much, if it's relatively less, they do that. They put their finger inside or keep, flapping their external ear. And that could indicate that probably the infection is around the corner and things like that. So once we know that no amount of touching or pulling is creating a problem and still the child has got pain in terms of crying, not accepting feeds, etc. Some children can explain, some children won't be able to explain because they just start crying for no reason, they stop accepting feeds, then you can kind of judge as to what's happening. Then in addition to that, you're also looking at other telltale signs, which Jagdish pointed out. One, look at the child's face, you know how much bothered the child is by the symptoms. Relatively better looking child versus a child in deep distress. Of course, since their consultation is from home, probably this is the only additional plus point of video consultation, that you have not taken the child out of the natural environment and brought them to an unnatural environment of the hospital. That's probably the only plus point. Other points are all very important, but it's not the best. So we have to opt for the second best.
So, sir, I completely agree with you. I mean, that's the only plus point, because if the child is actually irritable or if he's not irritable, that can be identified really easily. Now, Dr. Ramar, what I'll do, I will hand over to Fardeen, and he'll be taking the small workshop, a 10-minute workshop to teach all the doctors to how to take the high resolution images. And Dr. Ramar, definitely we are expecting a lot of questions about the examination, nose examination. So let's connect during the Q&A session. Now I'll stop projecting my slides, and I request Fardeen to put his video on. And I think his session is really exciting.
Thank you, Dr. Suchita, for the introduction. Hello and a warm welcome to all the doctors, panelists, and the team at PNG. Hope you all are doing well. I am Fardeen, a creative enthusiast based out of Mumbai, and I specialize in digital photography. While I started to build my career in the architecture and interior domain, my spare time was always devoted to the camera and to capturing a lot of built spaces, people, and everything that I would see and feel in life. It was only after a lot of YouTube videos and professional courses that I decided to pick up photography as a career alternative, moving it more than just a hobby. My photography has found its niche in the architecture and interior domain, and at the same time, my passion encompasses capturing people at their best in their candid moments. With the onset of 2020, I started a micro business, which encompassed assisting local brands and individuals to set up their digital presence. I started offering portfolio websites and startup e-commerce websites for these challenging times where digital presence and digital communication has become the key. The pandemic has shifted the dependency onto these virtual platforms and inadvertently pushed everyone into the digital space. Considering the current COVID-19 pandemic that has affected the doctor and patient face-to-face meetings as we all know it, teleconsultations has gained momentum and has helped in reducing the spread of illness. This special pre-recorded session is being conducted by PNG with a view to guide you on how to take the best photos as well as videos, in some cases to have better teleconsultation with the patients. In this short video presentation, I am going to cover 3 essential points. The first being how to adjust lighting and the camera position for video consultations. Second is how to conduct an examination over video consultation for the nose and the throat. And third, I shall be sharing tips and tricks on how you can assist your patients in using their mobile devices to get you better photographs and videos to help you with your diagnosis. So let's begin. While everybody today has access to mobile devices and can click a photograph, there are certain aspects which we need to look into when photographing with a goal in mind. I shall share tips on how you can guide your patients, and in this case, their parents, to ensure that the consultation and diagnosis process is smooth and effective. We're going to address this in 2 sections. The first is how to have a successful virtual consultation, and the second is how to assist your patients in sending you high-resolution images and videos. In either scenario, the first thing you need to ensure is that the patient is in a well-lit space, as in they're facing a light source. The light source could be anything. It could be the window at daytime, it could be the iridescent tube inside the home, it could be a table lamp or a night lamp in certain cases, and if nothing else, a flashlight. A basic rule of lighting is that the camera adjusts and adapts its exposure to the bright light in the image. So, in cases where the backlit is brighter than the subject itself, the camera will focus on that brightness, and in turn, your subject, as in your patient, would appear as a darker silhouette. This is one key element which we need to avoid. For instance, right now, I am facing my source of light, while what is behind me is less illuminated. Let's dive into the virtual consultation process. The first thing before diagnosis is that you ask the patient to be in a well-lit space.
This would be the general setup for an ideal video diagnostic. The patient needs to be in a well-lit room. The neck should be exposed. They should have a flashlight handy, and ideally, they should have somebody nearby to assist them.
If you take a look at this video, for instance, I am facing my laptop, which is my only source of light in the room. As I move away from it, there is like a darkness on my face, and as I come back to it, it again illuminates my face. However, it is dark all in all. This can be fixed by just switching on the ambient lights. This small aspect makes a lot of difference, as you can see in the video. Ask them to bring the camera up to their face to ensure that the face takes up most of the screen. I would ideally suggest the portrait orientation, which is vertical, while examining orifices such as the throat, ears and nose, as it will help capture the entire space. However, it also depends on what screen you're using. So if you are on a mobile, a portrait would make sense. But if you are on a laptop, a landscape would make sense, which is horizontal. With regard to the camera angle, you will need to speak to your patient as to how and where they can move their camera as to give you the best view. As we're dealing with orifices, there will be a need for an additional light source. This could be a mobile camera torch or a flashlight. These help brighten up positions and angles, which will help you get a better idea and a better look at the orifices. Because naturally, even when you spread out your mouth, it's dark. But if there is a source of light, it helps illuminate that part of the body. However, if you need to examine something that is on the surface, as in the external part of an orifice, then an additional lighting might not make sense, as the brightness of the light might flush out what you're looking at. There are certain pointers that you can follow and suggest when you ask your patients for high-resolution videos and photographs. The best way to easily accomplish this, especially in case of children, is to have the parent assist the child. You can ask them to take a normal photograph with the back of the camera. However, there are two key points that you should keep in mind while doing so. The first is to ask them to set the camera flash to forced flash, not automatic, not no flash. The third option, which is forced flash. The second thing you need to focus on is that they tap on the part of the screen which needs to be in focus. All mobile cameras have an autofocus function, and that helps you focus. In case when you're asking for photographs of the throat, you can ask them to make sure that the focus point is at the back of the throat and not focusing on the teeth or the lips. As well as, what you can do is ask them to open their mouth really wide. In my recommendation, it is always better to use the back camera, as it is a crisper and sharper camera, rather than the front camera, as it often lacks that same level of clarity. In addition, the flash at the back helps get you a better picture of the orifices. However, there may be situations where the patient might not get the assist that they need to get the right photograph. The best solution to that is to stand in front of a mirror and complete the same process as we discussed earlier. What the advantage to this is that the patient gets to see the phone screen in the mirror and they can focus on what needs to be captured. While using the front camera, there is one aspect that you need to ensure is to enable the post flash. This is an option that many new smartphones today have. What it does is it replaces the traditional flash by brightening your screen to its maximum potential.
Here you can see me use the front camera with the force flash on, and you see how it illuminates the screen.
Another solution, which though not as practical as photographs, but in case you can't achieve a photograph, is to take a video with the flash on. I recently had to consult my dentist about something, and while she asked me to send her a photograph, it just did not serve the purpose. So the alternative that we went up to was to take a video. I held the camera up against my face, and I have results which I will show you. There are some disadvantages to taking a video as compared to the photograph. The first being freezing the frame on the right detail space to conduct a diagnosis might not always be possible and might not always give you the crisp, sharp picture that you want. Secondly, the file size is increased drastically when it comes to a video as compared to photographs.
Dr. Suchita was kind enough to be a part of this demonstration and shared photographs of her child, the first time around without any directions as a normal patient would, and the second time with following the instructions which you will recommend to your patients.
To quickly summarize the key aspects of a video consultation or asking your patients to send you high-resolution photographs is to request them to be in a well-lit space. Second would be asking them to use the back camera as compared to the front camera. Third, make sure that the flash is on while photographing an orifice so that the space is well lit. Thank you for giving me your time and allowing me to discuss this with you all. I would be happy to open this discussion to you all as to addressing any certain doubts or queries that you all might have regarding this. Thank you.
So again, good afternoon, and all the doctors. I hope you like the video, and some of the tips which are given by Fardeen are like really simple, but definitely they will improvise the diagnosis. So my one question to Fardeen about the video consultation, and you actually made the point that rather than sometimes capturing the image, you can actually capture the video, which
Correct.
will always have the better resolution. So that can you explain to all the doctors that why the video will be better than the images that we capture?
So what happens is in images there are times where you can't focus on a particular spot, where you can't show that particular detail. What a video does is if you slowly move around that area in the orifice or maybe in the ear, if you slowly move around that area, it helps capture. I think the only downside to a video is the file size. So when you have to send it across and all as compared to a photograph, you're sending a larger file size. That is the only downside to it. Otherwise, a video is equally effective as a photograph where people like the doctors will be able to see the entire area. They can see like the sides of it as well. So, what the patient thinks might be the trouble area might just not be the trouble area. And, it gives you like an overall perspective of the space. So video also helps. But if you want to like stop and freeze on a frame or like go detail, like zoom in or something, in those cases, it has to come down to a photograph because their photographs are essential.
That's something which is very important, and probably most of us we have, I mean, we didn't have this idea, and I think it's a value add. Now, coming to Dr. Raman, sir, there's one question from the audience. We talked about nose examination, and we talked about ear examination. Some tips about the neck examination, because sometimes also that is also important. Is there any clues that we get from neck examination per se?
I'm sure Fardeen would have covered how to get better pictures, but then what we must remember is we need to see all around the neck. There should be a frontal view from the front with the chin up and with the chin down, then the left side and right side. And as you had mentioned in your slide very clearly, there's this muscle which can be easily explained by the doctor. There are nodes which could be in the front of it or the back of it. So, that area has to be seen or visualized properly. Left side, right side, front. These are important. Then, since the doctor doesn't have the tactile information of pressing, you need to ask the parent or to just put the finger, press, and get a perception of the size of the swelling around and also the height of the swelling, or so to say. So this is the thing. Thirdly, and importantly, sometimes you may have to ask the child to swallow and see the movement in the front and see whether the swelling, if it is there, it's moving along with deglutition, that is a swallow, or it's not moving with the swallow. It may not be as good as a regular physical examination, but it will give you an idea. Again, the ear part, front of the ear, back of the ear, side view of the ear, and sometimes in very rare conditions of mastoiditis, the ear is kind of pulled out of the ear because of some reason, or in the throat, for example, you have the when you see for one side the tonsil because of an abscess is being pushed much more to the other side. So all those things can be appreciated. Actually, the doctor should have a checklist when he's seeing the oral cavity of the ear. Another important point is the nose. In most children, all that the children have to do, in fact, with the speculum which we use to examine the nose, as you know, the child is very uncomfortable and will move. All it needs is to just push the front end of the nose upwards, and you can have a very good view of at least the front 1/3 to half the nose, from which you can find out whether turbinates are large, whether there are any secretions there, is there any obvious deviated nasal septum, is there any bleeding point? That's another thing. Children come with epistaxis. You can almost see because usually they have the problem in the front end of the nose. So they need to see the left and right. If they take the camera to the right level, you can even identify the clot or raw area in the nose, and that gives you a lot of perspective. So it's a continuous, I'm sure the photographic skills, like I was just telling Suchitra, that we should learn how to look at the patient through a photographer's eye. So
Yes.
we have to, be very discerning. And that's a great thing. I think it can be learned. We can't become very artistic like Fardeen, but we can learn how to appreciate good things in life. And in terms of the patient, good things means picking up the symptoms early and coming to a diagnosis.
I think, sir, beautifully explained. Sir, next question is again for you, and I believe it's very relevant question. So, the one question is from Dr. Devaji Rao from Tamil Nadu, who is asking how common is otitis media, because over the teleconsultation, is it like very frequent now to diagnose or to have a suspected diagnosis? And there is another question which is linked to it from Dr. Pawan from Madhya Pradesh, that how we can see the how we can suspect if it's a chronic otitis media case, maybe differentiating from acute otitis media.
Okay, let's go to acute otitis media first.
Yeah.
Acute otitis media most of the time accompanies an upper respiratory infection. And there's a particular age group, at least 80% of the children before the age of 3 have all had at least one episode of acute otitis media. The problem with acute otitis media is the child is just recovering from a cold, suddenly the fever might spike again, and you don't know the reason. The mother thinks that the child has become all right, and 3 o'clock in the morning, the child starts screaming at night. It really unsettles the family, and next day morning they want to see the doctor. COVID, no COVID, and if they can help not coming to the hospital, video consultation is very useful. So it comes after a period of when you think is normalcy, or sometimes, of course, it can continue immediately also, but then there could be a gap between the resolution of the upper respiratory, because it's a sequelae of the upper respiratory infection. So, like I said, there are what are called positive predictors of a particular diagnosis. Fever is a positive predictor, one of the highest degrees. Then the other things, where the child has had a previous upper respiratory infection, and then the children won't complain of pain unless they are older. They keep rubbing the ears, refusal to feed. These are and irritability. These are the things. And if there is fever and ear pain, I would consider by default that it is acute otitis. Okay, that is one. Now, chronic otitis media, the child would have had multiple infections earlier, and then one of those infections, the child is the perforation has not healed, and the child continues to get discharge. Again, otitis media can be classified in various ways. Acute otitis media, recurrent otitis media, persistent otitis media, these are all part of the acute thing. But in between, there is one more segment, talking as a medical person to another medical person now, where the acute otitis media becomes better, but the child does not have acute symptoms, but the child has other symptoms like because of deficient hearing, especially if it's bilateral, because of biliary effusion, because fluid there. So those are the children who are ignored both by parents and by doctors because there are no acute symptoms. That is going to be difficult, but then parents might come out, say that the child is not responding when I call him. And parents are also very smart. I mean, we should give credit to so many parents who come to us, almost leading us to the diagnosis. Only thing is, you should care to listen to them. And many times, even if you don't suspect it, they will lead you to that position. So, medullary effusion is one thing. And second, an important thing to remember is, after acute otitis media, the fluid in the middle ear may not clear for a long time. So that could be one symptom which persists for a longer time, may require surgical intervention if it lasts for more than 3 months, just medical or waiting and watching within 3 months. Now, the question that you probably are asking me is, how are you going to look at the tympanic membrane? Yes, that is a challenge now, but I'm sure, the iPhone is going to probably make us all jobless as far as the diagnosis is concerned, or equivalent of iPhone. They are recording ECGs, they are finding out arrhythmias, they're checking out all kinds of parameters. But then these are all aids to us. We shouldn't think that it's a competitor. iPhone can never, I think Edgy Wells said that, the human beings are making computers, and computers are going to overtake the world. He said, I won't be worried till computers join together and create a human being.
I know.
Not going to replace us. Okay, so they are going to be aids where we can use our logic, our cognition, thinking powers to arrive at diagnosis, which still is far away. We are going to be employed, we're going to earn our money, not to worry. So there are going to be some solutions coming, and I'm sure Fardeen also will, over a period of time, with the feedback that we give him, people like him are going to come out with innovative ideas, and all that requires a small speculum to be attached. Unfortunately, Jagdish is away. He's one of those innovative doctors, much more innovative than me. He's got some fixture he puts in the camera, which he can see. But then there are devices which have been used in third world countries from the auxiliary medical workers to transmit these pictures of the tympanic membrane to the base doctor. So I'm sure that something will come up. It's just a question of time. Till that time, we have to use our clinical acumen, use the videos, and then history, and come to the diagnosis. Diagnosis is three-dimensional: the history, the examination, and investigations. So since the examination part is weak now, we need to supplement with more history and probably some more investigations.
So I absolutely agree with you, sir. I think in future iPhone will definitely come out with a simple app with a otoscope or something which can easily diagnose the throat or take the throat pictures also. Now there's one question to Fardeen, and he explained something about the landscape view and the vertical view. Fardeen, can you explain it a little bit more for the audience that where exactly we can go
Sure.
for a vertical view and where exactly we can go for a landscape view?
So, ideally, I would suggest it depends on the device you're consulting from. If you're consulting from a mobile phone, then you go for a vertical view because it covers most of your screen. Like right now, I'm on a vertical view, correct? And you're on a horizontal view. So my screen is narrower to what the viewing area is. So if I were on a horizontal, I would cover more space on your screen. That is the whole idea behind using a vertical or a horizontal orientation. Depending on the screen format you're on, you suggest the patient also use that similar sort of a format.
Noted, noted. Thank you so much, Fardeen. There is very important question from Dr. Lakshmi Sankar from Ernakulam, Dr. Raman, and I mean a little bit I'm having difficulty to understand, but I believe the question is important. What doctor is asking, if you think that it's a chronic case on over the video consultation, then do you recommend the rescue medication without any further investigation, or you should ask patient to come and wait and watch?
See, that is our judgment of the clinician. There are certain things which can wait. A perforation in the ear is not going to kill the patient. Again, when we started off this COVID season, we the patients into elective, semi-urgent, urgent, emergency, and the timeline that we had given was 3 months. At that time, we thought after 3 months, COVID is going to go away, but COVID is here to stay. So our definition of all these things has changed. That's the reason in the beginning we wouldn't even attend to our oncology patients. But right now we've started looking after them because otherwise they'll lose their lives and it'll become a catastrophe as far as their health is concerned. So we have to compromise. And here also, depending on the child's diagnosis, the urgency of the pathology is spreading much more. Airway problems in children, for example, can be treated, but at some stage, if it's going to be chronic, then you need to take care of those things. Very elective things like adenotonsillectomies, adenotonsillar infections and all can wait. So wherever it's possible, not so that we don't burden our health system, most important thing, like it said, is do no harm. As a doctor, you may not do good, but do no harm. We don't want the child to come to the hospital, get a COVID infection and go, or we don't want the child as an asymptomatic carrier come to the hospital and spread the infection to health workers. And if health workers like the nurses and doctors get infected, we are the super spreaders. We see 70 to 100 patients in India, we see doctor. So we're going to spread it to all of them. So there is a responsibility. Keeping all this in mind, I'm sure with your years of clinical experience, with this child is going to be handicapped in some way, or it's a threat to the child's life, or is going to likely to get a life-threatening complication. By all means, you need to call the patient quickly. And as Jagdish said, your rapport with the patient has to be more frequent than in a regular, pre-COVID era. With all this, I'm sure we can take care. All of us have the, know all to do all these things, and it requires a lot of common sense in this for the doctors to arrive at a conclusion.
I think I completely agree. The clinical acumen is something which is at the end is very, very important. And always there will be a gray area. So, and we know that we write at our heart. So we always go for the better judgment for any of the patients. Now, doctor, it's already 4:30. So, but then the questions are flowing. But doctor, I'll only take the last question and then we'll stop. Apologies for all the doctors who are asking many questions, but we'll make sure that these questions will get answered in some or other way. So, Dr. Raman, I'll take this last question. This question is about is antibiotics needed for the external otitis
Okay.
for otitis externa?
See, otitis externa,
Dr. Katie Johan.
grossly speaking, you know that otitis externa has two types. It is localized or circumscribed and generalized. So if it is circumscribed, that means it's a boil, a furuncle kind of. The other one is completely, the canal becomes almost closed. It's cylindrically narrow. That's a diffuse otitis externa. These are very painful conditions, and children who have atopy and some skin-related problems are more prone to this. Or it could be due to chronic ear discharge, where some of us at home don't follow good hygiene principles. When the discharge comes, we don't wipe it off; it just dribbles out from the ear, and secondarily it produces dermatitis of the external canal and the ear. So in these cases, usually because the skin is full of bacteria, as you know, secondarily always the bacteria invade that area, and the set of organisms here are slightly different. But one of the solutions that we normally empirically we feel that could be there. Usually it is staph or it is pseudomonas, and mostly for pseudomonas we use one of the quinolones. And quinolones can be used at any age as drops, so there's no problem about that. So we normally give Cipro, especially if it is green in color. Of course, Indians are experts in mixing and matching spices. We are the masala people. So we introduce half a dozen antibiotics in one drop, antifungal, this, that. We want a quick solution. We don't have time to wait. So there are drugs which are irrationally there, which have some kind of an alcohol in them. Then they have an antifungal in them. Then they have a antibiotic in them. All three, call it a masala medicine. The problem with some of these things is children with very tender skin may have a reaction to this itself, especially antifungals are keratolytics. They're very strong. So what happens, the tender skin, they tend to create problems and the children could become worse. So be very careful. Don't use these combination drugs. Use an antifungal if you think it's a fungal infection, because otitis externa could be fungal also. If it's bacterial, the safe drug is Ciprotic in the US or Cifran eardrops in India. You can use that. There are combinations with the steroids also, which you can use in case there's a lot of swelling for a short period of time so that the inflammation goes down. But most important is oral toilet, and in a video consultation, it's really difficult to do oral toilet. So you have to explain to the mother how to make a small wick with cotton, introduce it into the ear so that by diffusion it absorbs whatever fluid there is. The more dry the ear is, the faster the resolution. But this could be one of the non-resolving otitis externa, could be one of the reasons you may have to call a child, because the child is very distressed and it can get into chronicity. So maybe you'll have to get the child to the hospital. And some Westerners also use ointments, but it's difficult to put an ointment inside the ear canal. In the external canal, you can use any of those skin ointments, which can cover pseudomonas, or I said the other one is staph. So anything local can be used.
I think this was like covered entirely. I think the entire management of otitis externa, and thank you so much, sir. I think I'll not take a lot of your time, and we should stop. So first, Dr. E.V. Ramana, really thank you from bottom of
Thank
my
you.
heart. And I think this session, what you have taken for us, and even from Dr. Jagdish, it was very practical, considering the relevant challenges which are right now facing by all physicians across the India. Nothing was theoretical, and definitely it will be very informative and add value to the current practice. I also want to appreciate Fardeen because it was his first attempt to talk to doctors. I think in the first, it was like less than 10 days period. Actually, he understood the challenge and come out with a small workshop, which will definitely aid all the physicians and all patients also, and which will definitely improvise the diagnosis, and ultimately it will definitely help our patients. And that's the intent of Dr. Raman, Dr. Jagdish, and even PNG as an organization. Fortunately, at the last, I just want to quote that we are very fortunate. I'm just taking it positively. Imagine this corona pandemic happening 20 years back. That time we didn't have any smartphones. we didn't have a lot of technology. So it's still okay. We have technology with us. We can do a audio consultation, video consultation. We can still help out our patients, and we can limit the exposure and limit the pandemic situation. So now I will stop. And doctors, I mean, please put your comments, feedbacks, and we'll definitely consider. And if you need any further topics, if you want any different topic, please let us know. We'll definitely try to organize it. Thank you so much. Thank you so much, Dr. Raman. Thank you
Thank you
so
so
much.
much.
Thank you, Fardeen.
Thank you.
And thank you, Exicon and Omnicurus team for all the help. For all the help. Thank you so much.